Good morning, everyone, and welcome. My name is Oscar Guzman with T2 Biosystems, and I want to welcome you to our Learning Lounge, Acting on Results, How Culture-Independent Diagnostics Impact Patient Care and Stewardship. Our speakers today are Dr. Audry Hawkins. Dr. Hawkins is the System Clinical Pharmacy Coordinator of Antimicrobial Stewardship at the University of Louisville Health System. She's actively involved in Joint Commission compliance as well as maintaining an ID pharmacy practice residency. Dr. Hawkins is also very passionate about integrating infectious disease diagnostics into practice with the purpose of improving patient outcomes. Our second speaker today is Dr. Navaneeth Narayanan. Dr. Narayanan is a clinical associate professor at Rutgers Biomedical Health Sciences and adjunct associate professor at Rutgers Robert Wood Johnson Medical School. He practices as an infectious disease pharmacist at Robert Wood Johnson University Hospital in New Brunswick, New Jersey. Please join me in welcoming and thanking both of our speakers for being here today, and I'll turn it over to Dr. Hawkins now.
Hello, everyone. Thank you, Oscar, for that wonderful introduction. And I'm very grateful that T2 has asked me to come today to talk about UofL Health's experience utilizing T2 bacteria. So full disclosure, we do utilize T2 bacteria and T2 Candida, but we're going to have a great presentation on T2 Candida right after this, so I'm going to focus on T2 bacteria. We'll move through this presentation keeping these three objectives in mind. So we want to understand the function and indications for ordering T2 bacteria, and then we're really going to talk about how we utilize and implement T2 bacteria in our health system. And then finally, we're going to have a little fun with some cases that were recently encountered at UofL Health to show how we are making clinical decisions utilizing T2 bacteria and what we're doing with those. So first, what is the T2 bacteria panel? So T2 Biosystems actually offers the first and only FDA-cleared test direct from whole blood. And what this uses is magnetic resonance to detect 5 organisms on their T2 bacteria panel, and this is independent of a positive blood culture. So you're getting these results within 3 to 5 hours from that first blood draw, allowing you to make optimal changes for your antimicrobials within that time frame. If you're comparing that to the standard of care, we know that when a patient presents with sepsis, you get a blood culture, you can confidently start antimicrobials, and depending on what technology you have available in your health system, this can take anywhere from 1 to 5 days to get an identification of an organism in your blood culture, which is therefore prolonging your time on empiric broad-spectrum antimicrobials. Now where T2 comes in is it gives you this direct from whole blood identification of an organism on this targeted panel within 3 to 5 hours, therefore decreasing your time of your broad spectrum, broad net empiric antimicrobial therapy, or maybe allowing you to optimize or kind of sidestep transition in what we're actually treating our patients with. And we know that this is important because in these patients with sepsis, hours and accuracy matter. As you're prolonging your time to appropriate care, you're simultaneously increasing your risk of death, decreasing your rates of survival, and then empiric accuracy, again, is very, very important. We like to think that we cast this very broad net of empiric antimicrobials in these patients with sepsis, but we know sometimes we kind of have to sidestep, we have to change course, we have to change path, and it would be really nice if we knew that earlier so that we can try to make a dent in this 2 times higher odds of death with inappropriate antimicrobials. When you really should be considering T2 bacteria is in patients as a part of their initial sepsis workup, and you'll see at UofL Health, this is where we've really tried to emphasize it and incorporate it. And then again, if this was not a part of your patient's initial workup with sepsis, you can kind of come behind, and we recommend it in patients who initially might not have had a T2 bacteria, but they're still not improving. And this is because it's not very impacted by the use of antimicrobials. The panel identifies these 5 organisms. So again, you will get either the presence or the absence of these organisms with the understanding that these organisms would be what's causing your sepsis syndrome. So you've got E. faecium, Staph aureus, Klebsiella pneumoniae, E. coli, and Pseudomonas aeruginosa, which we know accounts for upwards of 69% of bacterial pathogens that cause bacteremia worldwide. Now over in UAE, they have Acinetobacter added to this panel as well, and when you add Acinetobacter, that number jumps up to 74% of bacterial pathogens. So here, not only do you have a broad array of antimicrobials for your patients, or a broad spectrum in your patients with sepsis, but you can really broaden that net of diagnosis as well with them. We also know that it has a 90% sensitivity and 98% specificity for these organisms. And again, it's not affected by antimicrobial use, which when you're taking these things into consideration, this can really help guide clinical decision making in our patients with sepsis where those hours and those accuracy do matter. Where we implement this at UofL Health, again, is really trying to enforce it in our sepsis ordering policy. So it's a part of our sepsis bundle. We try to target those patients knowing that we can get our time to empiric and appropriate antimicrobials to be much shorter and hit them kind of with what they need right up front instead of waiting days and days and days to then target their therapy. We do say that you have to have an accompanying blood culture. So this is more of a screen is how we like to think of it. It's a screen for what my patients are going to have. It's not an end-all be-all. You still need to grow some bacteria to get those susceptibilities. So the point with the accompanying blood culture here is that you can compare it, right? So maybe you have a T2 positive with E. coli. Well, hopefully you would be able to get that E. coli on a blood culture, therefore get your susceptibilities. We know this does not always happen, but that is the goal right there, trying to take advantage of the bacteremic cycle in these patients. And then due to the screening nature of it, currently we're recommending that it's only not to be repeated within 72 hours. Given the very, very low threshold of detection, it's like 3 to 5 colony forming units compared to other types of diagnostics. There's not any clinical data right now, I say right now, but hopefully there will be in the future on repeat T2s and if that has any changes in clinical outcome or if that correlates to any sort of clinical outcome. So our hesitation here is that if you detect a T2 within 72 hours positive again, yeah, you're probably going to because it has such a low threshold. It's not affected by antimicrobials, but we don't know how that translates into clinical outcomes for our patients, so we currently would like to avoid that. We then have this wonderful caveat that makes all of our medical residents feel better, that if you forget it this morning on rounds or before rounds, you can obtain it if you get a simultaneous, again, peripheral blood culture. I've personally never seen an extra hold sample actually be obtained. I don't know if that's current practice at any of your facilities, but we're usually asking people to get another set of peripheral blood cultures with their T2 bacteria if they want to investigate utilizing that tool. We restrict it to our immunocompromised patient population. So at UofL Health, we are a relatively new health system, and we're composed of an academic medical center, what I like to call a hybrid community academic medical center, where we have our solid organ transplant cardiovascular patients. And then we also have a variety of other community hospitals and regional sites as well. So we're really trying to target these places in which it would have the highest yield and the most utility. We have our immunocompromised patient populations, our very high volume septic patient populations in our emergency departments and our ICUs, and of course our infectious diseases providers can order this whenever they need to. And the point of having this restricted really plays into diagnostic stewardship and how that then interplays with antimicrobial stewardship. And having an informed and an educated decision to guide this clinical decision making will eliminate the risk of false positives and misinterpretations of those positives, or if you maybe have some discordant results, being able to accurately and appropriately add that into your clinical decision making for your antimicrobials. Okay, now I said we were going to have some fun, and so we're going to have some cases, and feel free to raise your hand or interact as much as you would like. So these are, again, very real cases that we have had here at UofL Health recently. So our first is a 51-year-old male who came in with acute decompensated heart failure. He has a history of IV drug use, hepatitis C, cirrhosis, and diabetes, and he also had some complaints of a urinary tract infection upon admission, so they started him on ceftriaxone for an E. coli UTI that was later confirmed via urine cultures. Moving to hospital day 4, he experienced a new septic event. So at this time, on his new septic event, we obtained blood cultures and T2 bacteria, and we escalated him to vancomycin and pip/tazo. And if you have any comments or questions about the antimicrobial therapy, I would love to dice some of that out with you. So again, we got a T2 and a blood culture at the exact same time, and a few hours later, T2 comes back. The blood culture didn't come back until almost the next day. But it was very interesting. It was something that was relatively unexpected, right? We had a Staph aureus on our T2, but we also had an E. coli. However, later during our blood cultures, we noticed that only MRSA was identified. There was no E. coli identified. So does anyone have any thoughts on how you would potentially interpret this result? As accurate, yes. So in the crowd, they said as accurate. And that is a what we came to the conclusion as well. So this patient had a new MRSA bacteremia. They were inpatient. It was probably some sort of line infection. Maybe it was present on admission and it just now kind of was showing its head. But we also accounted for maybe a urosepsis. It could have also been there on admission. We know sometimes these patients with urosepsis don't show up as sick as some of the other infections they do, and that they likely had a urosepsis from their E. coli UTI on admission as well. Now, some other things that we had discussed were, well, is this a new E. coli infection? Maybe did we kind of mistreat the ceftriaxone or inappropriately utilize the ceftriaxone? And I can go on and on about dosing and selective pressure and all of that, but I'm gonna avoid that here. But what we ended up doing was keeping them on vancomycin and de-escalated them back down to piptazo based on their risk factors for their MRSA bacteremia, their susceptibility profile, and they were able to complete out their therapy for their urosepsis and avoid any extra gram-negative coverage while completing therapy for their MRSA bacteremia. So the next culture, or the next case, the culture-negative nightmare, I'm sure many of us have experienced this. This happens a lot in our surgical ICUs and our intra-abdominal patients. So I'm going to set the stage here for an intra-abdominal nightmare, or what I like to call the black hole of gram-negative coverage. This is a 52-year-old male. He's on hospital day 47. He initially showed up with septic shock due to pneumonia. He has a history of liver transplant, chronic pancreatitis with stents, and he's had a very, very complicated hospital stay involving 31 days of broad-spectrum antimicrobials. And if your math is accurate, you know that that's not divisible by 7, so maybe some of our durations of therapy can be a little questionable, but this man has received 31 days of therapy so far in his 47-day hospital stay. On hospital day 47, he had a new septic event. We got a T2 bacteria and blood cultures obtained, and this is what popped up. Again, your T2 bacteria comes up within 3 to 5 hours. Your blood culture was negative. There was no positive blood culture, so we didn't get anything on the gram stain. We didn't get anything on blood cultures. But utilizing this positive T2 for eFeциum and subsequently these negatives, right? So we know here this man has received 31 days of broad spectrum therapy, including gram-negative coverage. We were able to de-escalate him to 7 days of targeted linezolid therapy, try to eliminate any sort of concomitant damage that we were doing with any further gram-negative therapies, because I know at our institution this would have alluded to piperacillin and tazobactam probably for another 7 to 10 days, despite him having received that at some point. And so we were really able to give him targeted therapy despite our cultures being negative in this patient. And then our last clinical case, predictions with positivity. This was a fun one, and this one had a lot of clinical decision thought processes. There was a lot of discussions around this patient, and so it was a fun one I wanted to present to you guys. And so let me know if you have any ideas or questions as we go through it. So this is a 62-year-old who initially presented with concerns for sepsis of an unknown origin. I'm sure all of our favorite types of indications that we see on our antimicrobials. He had a history of interocutaneous fistula, and he was on TPN for this. He had a very complicated hospital stay too. He was transferred to the ICU on day 18 due to a new septic event amidst a course of piptazo that was started on the floor. And all of his previous cultures were negative, so everything up to now was negative. However, he was empirically started on piptazo due to some fevers, elevated white blood cell count, before he decompensated and was transferred to the ICU. So on his ICU admission, we obtained a T2 bacteria, of course, and we obtained sputum and blood cultures. And this is what we got. So this is, our T2 bacteria back very rapidly with Pseudomonas aeruginosa, and his blood cultures were no growth. So at this point, I like to think thoughts on how to act. So these are some of the discussions that we had in the ICU that day. Well, do we do anything? He's being treated. He was started on piptazo. We know that T2 bacteria is not necessarily affected by antimicrobial use, so at this point, do we not act? Which is reasonable, right? Is there anyone who maybe would have went down this route of kind of watching and waiting and letting him continue his piptazo course? Okay, so we would have all been on the same page then when we had this discussion. So we talked about how he did receive an escalation of care. He was hemodynamically unstable amidst this course of piptazo. We took into consideration our antibiogram, knowing he had been in the hospital for quite some time, and some of the places that he had bounced around in the hospital we know are a little bit higher rates of multi-drug resistant Pseudomonas infections. And so we concluded that this patient had a new hospital-acquired pneumonia. It was clinically correlated with his syndrome. And given his current anti-pseudomonal antimicrobial use and his clinical worsening, we actually escalated him to meropenem on hospital day 18. So that was the same day that he was escalated to the ICU and that we got all of these cultures. Within 3 to 5 hours, he had this escalation of care. Now, if we're looking at how our cultures followed up on that, here's where you can see where T2 really plays a role in this rapid escalation of care. So we got his sputum culture, came back the next day with Pseudomonas aeruginosa, and you're still thinking in your mind, okay, well, maybe he still could have been okay on Piptaza, or maybe he could have been okay on Cefepime, depending on your hospital's antibiogram or your local susceptibilities. And then a day later, so 2 days after we empirically escalated this patient, we got his susceptibilities back that confirmed our concerns that he had a multi-drug resistant organism. So with this, we were able to escalate him about 2 days sooner than we previously would have for his clinical picture, our hospital antibiogram data, and we're really using T2 here as a puzzle piece in this patient's clinical picture. And I think that is one of the main takeaways of our utilization of T2 bacteria. It is certainly not something that we use as an end-all be-all that we're blindly following. It is something that we use as a tool to help empower our providers in those moments to make a very rapid, quick clinical decision to optimize patient care. It's been shown to decrease length of stay for ICU admissions and hospitalizations. However, again, we do have a very strict ordering policy on this. That way we can increase the utility and the yield of these results. If we had it available for every patient on the floor, then everyone would be getting T2s, and then your utility and your yield would just plummet because you would be getting a lot of very, very interesting results. But that's all I really have, and if there are any questions about any of the clinical cases or you'd like to walk through them again, certainly feel free to. I think we're going to have a Q&A at the end though, right? So at this point I'll hand it over to our T2 Canada presentation.
All right, that was fantastic, and thank you to the organizers for this invitation. I really appreciate the opportunity. We've had T2 Canada for some time, so it's nice to really be able to talk about our experience here. So what we're going to walk through is really understanding sort of our initial implementation approach and really talk about the multidisciplinary nature of that, and then also just try to understand where T2 Canada for us plays a role as a tool, in the puzzle pieces that we have for antimicrobial stewardship and understanding how we work with both the positive and the negative results as well. As a reminder, but Audrey did a pretty phenomenal job explaining T2. For us, we're specifically focusing on the T2 Canada, so just as a reminder as to what the targets are across the T2 Canada panel, this is what we'll be sort of focusing on here. And so just as a brief introduction to our hospital and our health system. So we're located in New Brunswick, New Jersey. Our hospital, Robert Johnson University Hospital, is sort of the main academic medical center for a large healthcare system that runs across the entire state. It's a level 1 trauma center, so we see a ton of different types of cases. We have solid organ transplants, particularly kidney, pancreas, and heart transplants, and a large cancer center affiliated with the hospital. And they're actually building a new cancer center across the street as a standalone cancer hospital. And so we see a lot of hematologic malignancy patients, hematopoietic stem cell transplant patients, and then we have about over 80 ICU beds, and that spans medical ICU, neurosurgical ICU, cardiothoracic ICU. A lot of the referrals that we get are for cardiothoracic surgery, and we see patients with very severe cases of endocarditis that need cardiothoracic intervention. So we see a very wide range of patients. And so, I won't get too much into the details about sort of the pitch to the C-suite and how that worked, but we have really a fantastic microbiology medical director who was also the division chief, and so he really worked through that. But to fast forward after sort of the approval and then the understanding that we're bringing the technology in-house, the understanding of how to utilize this, a very different test, a direct from blood test, which is not from a signal positive blood culture, required a lot of thinking on how we do this from a process standpoint. So it was our clinical microbiology lab, it was our stewardship folks, as well as we actually had a representative from the Lean Six Sigma team from the hospital to understand how to actually implement this, and from A to Z in terms of from ordering, the nursing involvement, from the lab involvement, the calls that go to stewardship and whatnot, which we'll talk about in a bit. But that was actually a fantastic resource for us to understand how to do this from an implementation standpoint. And so the first thing that we did was actually try to get an understanding of what's going on in our hospital, right? So before we actually went live with the T2, we really wanted to understand the epidemiology that was going on locally. So we looked at about 4 years worth of data and then condensed that down to understanding really what the risk factors are and how we describe this sort of population in this cohort that we're dealing with that sees candidemia in our hospital. So we looked at various different factors, the care of the hospital, where they are, what floors they were on, what units they were on, who are the teams that are taking care of these patients, as well as sort of their characteristics medically, right? Are they critically ill patients in the ICU? Are they just solely immunocompromised patients but relatively clinically stable? And we wanted to also think about what are their main risk factors. And so when I say medical interventions, that means, are they on corticosteroids? Are they on chemotherapy? What are the things that we're sort of doing from a medical care standpoint that unfortunately put patients at risk just because of sort of collateral effects of chemotherapy and other things? And then when we think about the medical history or host factors, do they have a malignancy that puts them at risk? Are they in the ICU for quite some time? So all these things were really crucial for us to understand sort of what is going on in our hospital so we can best sort of roll out this novel diagnostic. And then the thing that really stuck out the most, and this is why I sort of presented this in the beginning, is looking at the 5 targets in T2, that comprised 97% of the blood isolates that we had over that study period. So the vast majority of what we were dealing with were those common species that we see. But just keeping in mind that although it's the vast majority, that it doesn't capture everything, and we wanted to also make sure we realize that it's not every single Candida species that we'll ever come across, but at least we're able to capture the vast majority at over 95%. And we also wanted to pay attention to our resistance rates to understand sort of what therapeutic we would be keeping in mind when we get these results post-implementation. And so how we did this, it was really very similar to what we've already sort of heard. Based on all the data and understanding the epidemiology of candidemias in our hospital, we were able to understand where this would probably have the highest yield and who are the highest risk patients. So we really rolled this out for sort of in a geographical way where we limited this to very specific units. So all our ICUs, our transplant units, where we particularly have a lot of our kidney transplant patients, and then the oncology units as well. But then we also sort of had free reign for the infectious disease physicians to be able to order it based on their expert judgment on units that might fall outside of these sort of geographic spaces. And I think the how is sort of the most important thing for us and why we wanted to sort of implement this. At our institution, we also have other rapid diagnostics that we use, obviously very different. They're from signal-positive blood cultures, but we really learned from an implementation standpoint, how to act on these results is very different depending on how you roll it out or who gets called and who's identified with the information. So for us, we had a antimicrobial stewardship program and a rapid diagnostic sort of service within that. And so there was someone from the stewardship team that would get called with rapid results. And not just with T2, but all of our rapid results. And so they would contact the primary team. If there was an infectious disease physician, they would contact them directly as the first priority. And so we went live with this back in 2016. And so the testing runs constantly. It's in-house. And I think that's something that some people might struggle with because, a lot of microbiology laboratories are being outsourced to different sites. But for us, our microbiology laboratory is in-house, and especially these rapid blood culture diagnostics are all in-house. And our stewardship service, where they get the call from the microlab in real time and then call the primary teams, that runs sort of in business hours. So Monday to Friday, 8 to 5. We learned a long time ago about sort of acting on results for different diagnostics that overnight it's really a challenge to get practice to change or the therapeutics to change. So we sort of maintained our sort of regular business hours for utilizing these rapid diagnostics in terms of calling. And so with that, I just want to go through some, representative case. So these are all real cases. So this was a 67-year-old male with a history of hypertension and diabetes, and he came to the cardiac ICU after an MI, and this was weeks ago. So the sort of quick rundown, patient coded in the cath lab, CPR, ECMO was started, and then eventually decannulated, and then the pressure requirements started going up with fevers. The patient ended up having Klebsiella pneumonia bacteremia, got Pip/Tazo for 7 days, and then was extubated. So now fast forward to sort of where we're at now. So now the pressure requirements are going up again. The patient has new fevers and a higher white count. So blood cultures, urine cultures, and respiratory cultures are all sent. And this is right before the ID consult was sort of tapped in to see this patient. And just keeping in mind that the patient had lines where they had a femoral line that was recently removed and now has a left IJ line for about 8 days at this point. So in terms of the testing that came back, so a T2 was sent along with the blood cultures and whatnot, and so this actually came back positive for Candida parapsilosis. So the patient was started on micafungin, and also they had respiratory cultures that came back and it was positive for Klebsiella, and they were restarted on Pip/Tazo for better or for worse, and I think that's a different conversation in someone that might not actually sort of mechanically present as a pneumonia, but that's something we won't be talking about now because it gives me heartburn. So at this point now, this is day 2. The left IJ is removed. They put a subclavian instead, and then the pressure requirements are stable, and the blood cultures are no growth to date at this point. The therapy was changed following the results after a day of micafungin to fluconazole. And like I said, the Pip/Tazo was continued just pending the blood cultures. But by day 4, the patient's pressure requirements were going down. The patient was afebrile. The blood culture was still no growth to date. And so they were able to discontinue Pip/Tazo because, like I said, this patient clinically didn't present with pneumonia, although they had positive respiratory cultures. And this patient was continued on fluconazole for 2 weeks, and an ophthalmology evaluation was taken. And that's also something that can be sort of debated. And there was a nice session at one of the ballroom sessions about the ophthalmology consults and sort of their issues with that. But then at this point now, on day 7, the patient was off pressors, afebrile, awake and sitting in the chair, and then eventually got discharged to LTAC by day 14 with no antimicrobials. And so this, I think, just illustrates sort of the utility and, a clinically compatible case with someone with the line, and understand that Candida parapsilosis obviously has some affinity for line-associated infections, and someone in the ICU that's been in the ICU for a while, received broad-spectrum antimicrobials, and then presented with a clinically compatible case, but where the blood cultures, the sensitivity is sort of lacking in that area. And so that's our main takeaways, is understanding that, T2 obviously has that sensitivity, and blood cultures, conventional blood cultures, are not able to sort of capture everything. And also the time to positivity is vastly different. So for us, that is also a sort of crucial factor, especially in these critically ill patients. So we're looking at, time to positivity in the order of hours. It could be about 3 to 4 hours. While, blood cultures, especially when we're looking at that study that we did before, the time to positivities, even for blood cultures, if they turn positive, could be on the order of days, right? And sometimes, we're not always thinking about empiric antifungals, so patients can be missing a crucial therapy. And also, it was really, sort of understanding who needs to be tapped in. And it could either be the Stewardship sort of rapid diagnostic team that helps, and that's really comprised of ID physicians, ID fellows, and ID pharmacists, or it could be just directly having the ID consult involved directly. But honestly, the fact of the matter is, the number of negative results that we see vastly outweigh the number of positive results that we're capturing, right? So this is just some basic utilization data over the last year, or over this year, and you can see right here, these are the number of positives, right? And the top row is the denominator, right? So this is a very, low positivity rate, but when they are positive, and especially when it's positive much faster, and it's T2 positive, culture negative, there's obviously utility in that. But just understanding that the vast majority of the cases in the tests that we do end up being negative, right? But for us, that actually has a lot of utility and understanding in how we use that. But just keeping in mind, the ultimate decision of starting or stopping someone on antifungal therapy, that's always a patient-specific decision. There is not some broad, hard and fast protocol that you absolutely have to stop antifungals, or you should start them and then stop immediately. But we take it on a case-by-case basis on sort of how to interpret and use these results, particularly how to use the negative results. So I'll walk you through a case that sort of demonstrates this. You have a 55-year-old female recently hospitalized with multi-drug-resistant bacterial infections. The patient had a pneumonia and sepsis. Right now is intubated in the ICU and on dialysis. This patient has end-stage renal disease, so is on dialysis sort of at baseline. And now admitted for cardiac catheterization, has a cabbage, and now post-op is intubated in the ICU with hemodialysis. And so now there's, on day 3 of their operative procedure, they have new fevers and altered mental status. And so blood cultures are sent, sputum cultures are sent, empiric antimicrobials are started, and then ID is consulted in this case. And so for the ICU team, the patient was started on miro and micafungin, which I feel like makes some people cringe, but that's what they started, at least initially. And they were recommending, following cultures and following up ID recommendations. And if you look on the right side, I mean, this is the sort of list of risk factors specific to this patient. There's obviously a lot more risk factors that exist that can put patients at risk, but specifically for this case, this patient was recently on broad-spectrum antimicrobial therapy because they had that multi-drug-resistant bacterial infection recently. This patient has end-stage renal disease, is on dialysis, at home and even during the hospitalization. A little less than a week ago, the patient had a positive urine culture for a candida, and this patient has a central line in place. And so at this point now, the patient has persistent fevers, their mental status is sort of waxing and waning, and by 10 a.m., the ID consultant puts in a note, is more concerned that maybe this is non-infectious in terms of the cause of fevers and potentially pneumonia, but it's still sort of evolving clinically as to how the patient's presenting. So along with, following up the other results, they also send a T2 Candida test. By later that afternoon, because obviously the speed and the turnaround time, we see that, none of the targets were detected. And so for the index of suspicion that the ID physician had going in, so their, sort of pre-test understanding of sort of where they place, invasive candidiasis in the hierarchy of what's going on for this patient, the ID physician recommended immediately stopping, antifungal therapy. The patient had 1 dose of micafungin. And so, the difference really is understanding sort of the ICU perspective of this patient has fevers, we need, a broad spectrum antimicrobial coverage, not to oversimplify it. Obviously, there's a lot more thought that goes into that. But from the ID perspective, based on their exam and based on their whole sort of understanding of the patient and what's going on, there was this thought that, it could be non-infectious, maybe it's a pneumonia case, but there's a very low concern for candidemia for this patient, right? And what actually ended up happening is that the patient the next day started having a lot more secretions. They were able to get respiratory cultures. This patient sort of clinically presented themselves as a pneumonia, and this patient actually ended up having an MDR pseudomonas pneumonia. They got switched from meropenem to ceftoltezo. But this just shows you that the case went in a very different direction, despite the fact that this patient had multiple risk factors for candidemia, right? So, understanding that a risk factor is what it is, but, its predictive value might be very different than just understanding is this patient at risk for invasive candidiasis. Oops. And so, this is, I think, the part that really tries to hit home in understanding. So you have the performance characteristics of T2 and understanding where its specificity is as well. And then if you look at the negative predictive value, depending on the prevalence of disease, or, the other way to think about it is sort of your pretest probability of them having candidiasis, the negative predictive value is extremely high, right? And, the general sort of thought is that, maybe candidemias represent, I think the specific number is 6% of hospital-acquired infections, right? In that large study that was done in the New England Journal about understanding the sort of etiologies of hospital associated infections. So living in sort of this area, even at a higher prevalence, the negative predictive value is still extremely high. So the utility really helps us from a stewardship perspective in patients that have a low pretest probability of candidemia, and then just adding a sort of very accurate piece of information to help change the antimicrobial therapy based on sort of the whole clinical picture. And so our main takeaways is, like I said, we had an ICU patient with candida risk factors that was on, empiric antifungals, and, those patients weren't consideration for antifungal therapy, right? But the risk factors alone and these prediction models, they really underperform. The IDSA guidelines for invasive candidiasis make clear note about this because of the fact that these, candida scores haven't really taken off because of the fact that they're not that sensitive, they're a bit cumbersome, and they don't work as well as that you would want them to perform. And the thing is, empiric antifungals, it may be beneficial, but there's always a cost there, right? Between toxicity, financial cost for the institution, as well as resistance that can emerge when you have, repeated exposures to echinocandids or azoles. And those are also important things to weigh against the low risk of candidemia. And so, this case sort of really reflects like our earlier experience, and this is something that we presented at IDWeek some years ago, but still is sort of a representation of how this sort of works in our institution. So I'll sort of just quickly walk you through this, but in this, this was a nice fellow-led project that Rashi presented some years ago, but she looked at 50 patients with negative T2s, and there was a pretty clean split of patients that were never started antifungal therapy, and then patients that received antifungal therapy at that time. And then from the patients that were on antifungal therapy, it was about a 60-40 split in terms of what happened, right? So most of the patients ended up stopping antifungal therapy with the median time of about 2 days, and then 11 patients, or 42% of patients, continued. But the reasons, and this is why we say we do it on a case-by-case basis, the reasons are all very compatible, right? Some of these patients were on antifungal prophylaxis anyway for their hematologic malignancy. Some had positive cultures for Candida. A couple were Candida species that were not on the panel, right, like Lusitania and Garamendi, and so those were positive blood cultures for that. And another patient had a positive culture days prior, was on antifungal therapy, and then had so continued on therapy at that point. Why they did this test for that patient, I'm not sure, but that's part of the reason why this patient's continued on it, right? And then there was one case that they just felt that they needed to continue empirically based on their clinical picture, right? But the takeaway here is really that the vast majority of patients were either able to avoid antifungal therapy or they stopped. So this is just a basic general understanding of our early experience. And so this is sort of how we approach it as our general guidance. So we look at it in two different ways. Patients who have been started on antifungal therapy already, and then based on their test, obviously if it's positive, then it's really focusing on the species that was positive and trying to tailor therapy appropriately. But if it was negative, it's sort of the option of continuing empiric therapy or stopping. And a lot of this has to do, like I said, with being one piece of the puzzle and not just the only thing that we sort of go off of. And so the other sort of perspective you can take is just patients that may have a low suspicion of invasive candidiasis, so therapy is being considered. And then at that point, if it's negative and you only are considering that you're going to start antifungal therapy and the index of suspicion is not high enough that you would have started them anyway from the beginning, then considering withholding antifungal therapy, but making sure it's a case-by-case decision. And obviously if it's positive, starting species-specific antifungal therapy. So for us, we've just went over, our goal of trying to hit high-risk units, high-risk patients, and sort of being able to test these patients and utilize this in the right population. That's basically what we went over. But for the future, part of this is making sure we're able to capture as many of the patients as we can that are at very high risk. So one of the things, which obviously takes a substantial amount of time to coordinate anything with our electronic medical record, is for ICU patients particularly, when the first blood cultures are sent in septic patients, to have the T2 automatically sent, so it's not sort of something that has to be added on or relying on the team themselves. Although they send it a good amount, some are obviously missed and not sent. So hopefully this is sort of where we're going with this in the future. And with that, I'll conclude, and I'll be open to any questions as well as Audrey.